However, it was later discovered, through no fault of the consultant, that 50 to 70,000 records actually were not turned over at the same time. So those records that are being turned over later will also be scrubbed, and that will be used to update the report. But the way our contract is designed, it would penalize the consultant with fines for a delay that they were not responsible for. So the task force members have an amendment on their desk that simply allows the Stevens Group to have a little extra time in October to get that done. And it also retains the teeth that they will not receive their October payment, if they don't get that done. So I consider this a relative technicality. Senator Chesterfield, do you have a question? We've got a move. Do we have a second? Senator Raper, second. All in favor? Aye. Any opposed? The amendment is adopted. Thank you. The second thing that we need to do is, as we're looking into the future, we've got the consultant's plan coming in October, and then we're going to have the final plan from the task force presented on December 31st. And as we're making that transition and moving into 2016, we're going to need our implementation contract as a next step. So there's a couple ways we can do that implementation contract, and in order for BLR to begin that process, we need to make a decision about the way we'd like to do the contract. And the two ways we can do it are, number one, use a sole source contract with our existing consultant for the new contract.
And I would like, given all the work that we've done, the fact that our existing consultant will be very close to the information and the recommendations, is very ingrained in a lot of the work that's happened. I think it'll be much more efficient and effective to have a sole source contract with the Stevens Group as the next contract. And I would like the committee, the task force, to authorize BLR to prepare that contract in that direction, so that we, at our October meeting, will be able to see the proposed contract and agree or revise or whatever, but understand that it will be a sole source contract. So if I could get a motion for that, or if there's any discussion. Senator Chesterfield. Do I have a second? Senator Rice seconds that motion. All in favor? Any opposed? Okay, thank you very much. So we will do a sole source implementation contract with the Stevens Group. Okay, now we're ready to move to item E on our agenda. That's these guys here, right?
Yeah.
Are they there?
Doug and Janie.
All right, so Mr. Stater and Ms. Cotton, if the two of you would please come to the end of the table and introduce yourselves for the record and who you're with. And as we get ready to have multiple outside presentations, which is different in my view from when we have our consultant sharing their learnings back and forth with
members, I would really appreciate it if we would recognize that there are going to be 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, something like 25 speakers this afternoon. And we don't have the ability to go into tomorrow, so if we just think about the time that we're using, I greatly appreciate it. Thank you very much, and sir and ma'am, you are recognized.
Thank you, Representative Collins and Senator Bledsoe. We are very appreciative to be here this afternoon to represent the Mental Health Council of Arkansas and our recommendations regarding behavioral health care going forward in Arkansas. My name is Doug Statter. I'm the CEO of Centers for Youth and Families, and I'm again here representing the Mental Health Council of Arkansas.
Thank you also for the opportunity. I'm Janie Cotton, the CEO at Professional Counseling Associates, covering Pulaski, Wilmington, Curry County, and also representing the Mental Health Council of Arkansas.
Awesome. You're recognized to share your thoughts.
All right. We do have a PowerPoint. I'm not sure if it's they need some help on it.
Bring it up.
But
Can you bring it up?
we're gonna work on an apple, so.
Double click. Yeah. Double. There we go.
Okay,
Is that it? That's it?
and we just click here to go? You want to handle that?
Is that it? Click here.
Yep.
Right there. See if that works. We don't want to do that. How about next? Well, we could bring up the slideshow here. What's that?
We'll get it just one.
Okay, let me try this. Go ahead.
There we go.
Okay, we are ready. I apologize. A little bit about the council, Mental Health Council of Arkansas for y'all's consideration. The Mental Health Council is comprised of 12 of the 13 community mental health centers that operate throughout the state. There are also 2 specialty providers as members of the Mental Health Council, Birch Tree Communities and Centers for Youth and Families. Cumulatively, we are responsible for providing behavioral health care throughout the state. And over the past 50 years, we have been the mental health public safety net in Arkansas. Last year, or in 2014, we served almost 70,000 unduplicated consumers in the state, and that includes 24-hour-a-day, 7-day-a-week emergency screening services available on a statewide basis. We employed about a little over 3,300 staff members this past year, and we are truly committed to what you've heard, I think, today from the Stephen Group and in the past, to looking at the least restrictive and most community-oriented system of care we can possibly provide that's both accessible, cost-effective, and outcome-focused. We embrace the principles of recovery and the provision of behavioral health care services to consumers across the state of Arkansas. The first one of our recommendations has already been presented actually to the Criminal Justice Task Force, but it does tie into what we feel is needed from the behavioral health care standpoint in Arkansas, and that's the sequential intercept model, and we're recommending that that model be adopted to be used in planning efforts for improving access to community-based services throughout Arkansas. This model will facilitate planning involving both local law enforcement, the courts, and the behavioral health providers to identify gaps in services. It's supported by the Arkansas Association of Counties and the Arkansas Sheriff's Association. And I think we saw or heard a little bit this morning about some of those gaps in service, the lack of jail diversion programs in the state. The San Antonio program was mentioned. The Mental Health Council has sent a group of representatives to San Antonio to study that model, along with representatives from the Sheriff's Association and some of the local courts. We've also have a planned trip to Tulsa to look at a similar jail diversion program there towards the end of this month. And at this point, I'm going to turn it over to Ms. Cotton.
Thanks, Doug. We really want to look at the continuation of the recommendations. As Doug said, we have been partnering with several partners in the state to just help us with holistic approaches to services, One of our recommendations is treatment compliance. As you know, a lot of our clients are seriously mentally ill and our SED children. And even though we want and support least restrictive environment, there are always those persons that cannot just have outpatient services or medication maintenance. And so we are recommending assertive community treatment team, which is called ACT, in each of the community mental health center service area. We had given information before at the legislative session for the ACT teams, and we're wanting those to be placed in the catchment areas as defined by Department of Behavioral Health Services. And the amount we had requested before was about $5 million. I'm not sure what the amount will be if we put them in each area, but if you look at what Birch Tree does in the system, they have been sort of the safety net for the ASH, the Arkansas State Hospital, and those persons who cannot maintain at ASH for longer periods of time with the shortages, they have fulfilled that through therapeutic communities. And so we're letting you know, I think someone mentioned earlier today that the jail personnel and the sheriff said there was nowhere to put people. Well, Birch Tree is one of those persons and facilities that has been utilized for that. And so we're recommending that if you give us the ACT teams and consider that in the recommendations from the group, you will see that component fulfilled for jail diversions. Also, compliance with treatment is a key component in the success of specialty courts, mentoring programs, and other reentry efforts. As you notice on the news, in broadcast, on the Arkansas Times, you find that many of the clients with mental illness have been jailed when they could have received mental health treatment. We have been the safety net, as Doug mentioned, for the state of Arkansas for public mental health, and feel that we can provide those services and have been collaborating to continue what we've already been doing for the last 50 years. We also support the existing public mental health center. We like to recommend crisis intervention services, including the establishment of crisis units. We went to San Antonio and we'll be going to many places. If you look at the preventive measure of treating those with mental illnesses and mental health concerns, if you catch it on the front end and you can get involved through the trauma-informed care or crisis units, you can prevent a lot of the long-term care that occurs. And so we are asking that consideration for recommendations. Care coordination is a critical element. I think I heard the guy from the Stevens Group say we were fragmented in our systems. If you had care coordination where everyone would be involved in that treatment modality to make sure that people get what they need, it wouldn't be fragmented. And we've done that as a part of community mental health centers. We take those clients at whatever level they are and provide those services for them. With that care coordination, it also gives us enhanced substance abuse treatment. If you remember, a lot of the clients with mental illnesses also share comorbidity with substance abuse. And so we're asking that that be enhanced and adequately reimbursed by Medicaid. We're asking to enhance the level of intensity community-based services in order to reduce inpatient and residential admissions. This includes a new admissions process with better identified protocols for approval of inpatient and residential care. I want us to be mindful that we can be the best system in the world. There will always be some clients that need residential and hospital care. That, I don't think that's going away, not in my 39 years of spearheading things for mental health. There will always be levels of care that different clients need. We just hope that we can spend enough time and energy on the least restrictive for those who can support recovery.
And if I could add, all four of those recommendations come from or are part of the Arkansas Payment Improvement Initiative project that was done for behavioral health in the last couple of years.
Correct. Our other recommendations is one of the requirements through Medicaid is a lot of paperwork, and people hear me say this for the last couple of years with that. And we're asking to save money for the state and to save more money so that we can do more clinical services. We're offering the elements of service as opposed to across-the-board percentage rate cut, change the time frame for review of treatment plans from every 90 days to a 6-month interval. That has been a 9% growth rate in costs over 4 years of services. Those of us who have been in this field for a long period of time feel that that is unnecessary and does not aid in maintaining care for the client. We're also asking that that money could be used for more clinical care and prevention services. One of the other ones we feel could be eliminated and ask for your consideration is to remove the requirements for reoccurring annual psychiatric diagnostic assessments. Our psychiatrists and doctors who are doing the work daily feel that that is not necessary, nor does it improve quality of care over a period of time for the clients because they see them regularly anyway for med maintenance. And we're asking that you look at that because that has increased expenditures for growth by 22% over 4 years. Also, nationwide and statewide, we have a shortages of MD and psychiatrists to provide the necessary services just to maintain staff. So we're asking that some of the duplication of the paperwork be discontinued so we can focus on the quality of care. And then last but not least, on our recommendations, as community mental health centers, we are certified by CARF accreditation or JCAHO, and we are recommending and have the propensity to become certified community behavior healthcare centers. And we're going to look at doing that also because that's also a way to uniformly cause us to be certified to deliver quality care by standardized outcomes. The community mental health centers and the Mental Health Council of Arkansas greatly appreciate the desire to cut access costs, but not at the expense of our clients who need services on a day-to-day basis. And this is based on experience and facts. Most of us have 25, 30, myself 39 years in this field and have programs that have been proven that the services are not only necessary, but they prevent children from being suspended, expelled in school, clients from committing suicide, and clients able to maintain in their own community. We know with our records that that has occurred. We ask that you look at the experience that we've had with success before anything is cut. Thank you.
Thank you. We have some questions for you. But I would like to ask first, on number 3, you mentioned that these came, A, B, C, and D, came from the Payment Improvement Initiative. Is that correct?
Yes, if you remember in the Payment Improvement Initiative, crisis intervention, care coordination, intensive community-based services, and I think substance abuse treatment was all a part of that Payment Improvement Initiative that we are, I don't know if we're still looking at it, it's on the shelf, I'm not quite sure. But those were the things that we agreed on at the beginning was necessary.
All right, but as far as participating in that with episodes of care or anything like that, you have not done that, is that correct?
The only episodes of care that we've participated in as behavioral health providers is the ADHD.
Okay, I understand.
This plan has not, the
Okay,
payment improvement plan we're talking about has not yet been implemented, but it is, as Janie said, on the shelf.
all right, thank you. Senator Irvin, you're recognized for a question.
Thank you. It goes to your crisis intervention services point that you put on here. One of the things I'm proposing in discussion with the governor and others is utilizing our trauma system for our mental health patients. I think that you already have an infrastructure in place. You have a trauma system that if you're going to maximize and utilize it, many times the reason why your county jails see mental health patients is because they're in the emergency rooms. And there is kind of a revolving door, and there's not a bed, and we can't find a bed for them. And there's no communication stream or infrastructure to identify where available beds are. And I think the trauma system could deliver that. And I wanted to get your thoughts on that.
I agree with you with the trauma system. We have, all through the Mental Health Council, have trained our staff members on new trauma-informed care with their regular licensure for clinical care. And we definitely support that. We've been looking at that. If you remember, we provide 365 days out of the year, 24/7 crisis intervention and screening processes. So we go to the jails, we go to the state hospital, we go to the regular hospitals to do an assessment so that we can do the least restrictive environments for those clients. And we have diverted a lot of clients from hospital care or going to the jail. We just need more opportunities to do that.
Well, I think you have a communication structure in place that could be utilized for that population, because emergency room physicians spend an inordinate, or their staff spends a lot of time on the phone trying to identify where a bed is to
That's
place
correct.
that patient, because the state hospitals, as you know, beyond capacity. So that's something that I would really appreciate you diving into a little bit deeper, because I think that's a good solution for a current existing structure we already have in the state.
We will definitely take that back. That's right in line with the discussions we're having with the Sheriff's Association and other local law enforcement, those same issues of finding the bed, finding the resources. And really, a lot of that would work right into that sequential intercept model we talked about, and putting that trauma system in at one of the initial steps of when someone
Presents.
presents in
Correct.
either to the jail or to the emergency room.
Correct. It can
One
be
of the
utilized for
great
both.
things at San Antonio, we went to visit there, and the relationship with the local police officers and everything, it was wonderful, because they were able to bring the clients to one of the programs from the community mental health centers in lieu of taking them to jail. And they had saved a lot of money, and we see it every day. It's something that you could prevent, because most of those clients are able to maintain. A lot of people try to think of violence, but it's not, that's minor compared to who we serve that are treatable and in the recovery process.
Appreciate it. Thank you.
All right, Representative Meeks, you're recognized for a question, and let's keep an eye on the time.
Thank you, Madam Chair. I appreciate it. Mine is on the point 4, I guess, recommendation of elimination of specific elements of service on that one. Because when you say you're going to save $3 million a year, of course, that catches the eye. But my question is it a state or federal law that requires you to do it on a yearly basis? And if it's a state law and you were to pull this thing out, are there other states that do not have this yearly? And would you have any data from those other states to find out whether it's been an improvement or not?
It's my understanding that is a state regulation
Relation.
and not a federal requirement. I'm sure the Division of Behavioral Health could address that when they come up in a few minutes, but we feel like, particularly when you're working with seriously mentally ill adults that have been in the system and been in your care for literally for years, that mandated annual evaluation by the psychiatrist who has been seeing this client ongoing every month for several years is actually just an extra piece of paperwork that we have to pay a psychiatrist or a physician to complete and do that evaluation and submit it. And that's very valuable time to the community to have a psychiatrist doing paperwork rather than seeing patients.
I would agree with
But
you.
we certainly will look at that from the other states' perspective and see
Yeah,
if we can bring you some data.
I'd like to know about that. And again, just, to have something in place to see how that patient might be doing. I would think that would be why you're doing the evaluation, to see if they're improving or if they're getting worse. And I don't know if there's an alternative to kind of, judge how that patient is doing.
Well, if you look at modalities of treatment, most of our clients come in at least minimum once a month to see the doctor for medication maintenance, and those who are doing better in their recovery process every 3 months. So the psychiatrist is already seeing them either monthly or every 3 months, and all we're saying is another piece of paperwork. They do notes every time that they do to validate the type of medication they're on. So this is just another piece of paperwork, and you may have already seen the client on the 11th month, and then you have to do this on the 12th month. And we feel like it is not cost-effective, nor does it give any credibility to increase enhancements of their treatment.
Okay, thank you. Thank you, Madam Chair.
All right, thank you. Representative Gray, you're recognized for a question.
Thank you, Madam Chair. 2 questions, I guess. One of them centers on your care coordination on number 3. Would that be equivalent to like PCMH for the primary care physicians? And do you think that the PCMH model is something that you could implement in behavioral health to where you had continuity of care throughout the entire period. A lot of times what we'll see is someone who's, been in a behavioral health system and they drop out of treatment for whatever reason, they end up back with us, then they end up back in the hospital, and it's just a vicious cycle. And if you could do what the patient-centered medical homes does, as far as you call the patients every week just to check on them, it's a 2-minute phone call. If they have any issues, you try and help them, and essentially then they have ownership too, the patient does, in their own recovery. So is that something that you think could work, and do you have any idea about cost savings for that?
Yes, ma'am. That is part of the care coordination was part of the behavioral health home. That was a component of the payment improvement initiative that was addressed. And it really is very similar. It's the same model as a patient-centered medical home.
Right.
The only difference is for these clients that are high-level need of intensive care clients, they would be identified, and their health home, rather than being the PCMH, would be the behavioral health home, where they're there several times during the week.
Right, and that's not
But-
something that's been implemented yet.
Has not been,
Has
but,
not been implemented.
but as the behavioral health home, we would be responsible for making those calls, making sure that that client was making their other physical health care appointments and coordinating that care with the other physicians.
Okay, and just a follow-up,
Yes.
just to that, do you have any, are there any other states that are doing something that have implemented that so far? And if there are, can you tell me, were there cost savings involved?
There are several. The one that comes to mind is Missouri, that started this several years ago, the behavioral health home. And I don't have it with me today, but they have had significant cost savings identified there. And again, the Mental Health Council visited one of those programs a couple of years ago, and it was having significant success, not only in cost saving, but in improved outcomes for those clients as well.
Oh, okay, thank you. And maybe I asked the Stephen Group to possibly get us the data just to see what that's been. And is there a reason we haven't implemented that yet?
My understanding was the initiative was ready to go in a waiver request to federal government late last fall. And at that point, it was kind of put on hold to see what direction we were moving in Arkansas.
Who put it on hold?
That I don't know.
All right, thank you.
Dr. Charlie Green is coming up in just a few minutes, and I think he might be able to answer that question. So I don't see any other task force members that want to ask a question, so thank you for that. We appreciate you being here.
Thank
Thank
you. We
you.
appreciate you allowing us to be here. Thank you.
All right, we're going to have number 2 and number 3 come up together.
I'll let him get it off.
All right, if you will take a seat at the table and introduce yourselves for the record, please.
Thank you, Madam Chair. Thank you for the members of the task force. My name is Robin Ravindran. I represent the Alliance for Health Improvement.
Turn your microphone on, please. Punch that button.
Okay, thank you. I want to echo our appreciation for allowing us to speak with you today. I'm Carol Moore. I'm a member of the Governor's Commission on Children's Behavioral Health, and I'm also the Vice President of the Arkansas Behavioral Health Providers Association.
I'm Dr. Max Baker. I'm a board
I think you're going, is your microphone on? Right, you
Thank
might
you.
want to pull it a little closer.
My name is Max Baker. I'm a board-certified psychiatrist practicing for about 45 years in Fort Smith, Arkansas. And I am president of the Alliance for Health Improvement, and I'm also a member of the Private Behavioral Health Providers Association.
All right, thank you. You're recognized.
Thank you. My presentation is basically on, by trade, I'm an accountant. I'm trying to give some cost savings measures from the current existing Medicaid behavioral health program. I have also, my background came from being in state government with DHS for 29 years. The last 12 years was with Medicaid. With those background, these are my analysis with our group that we are presenting to you in terms of cost savings that we could achieve if an opportunity was given to us. One of the main things that we looked at these programs over and over, consult with the clinical folks, and including conversation with DBHS, we believe some of these programs can be adjusted without having any significant effect to the clients we serve. So the first part of the piece was to reduce the current existing time frame to 45 minutes on the certain individual therapy, and I have a list of those I could provide to the committee later on a separate sheet what those are. We project those costs to be about $2 to $3 million. And on the second part of that is the same thing with the group side. We estimate that cost to be $1.3 million. But all these numbers are coming from the 2014 expenditure report that we obtained from DHS. Somehow we also have a difference in, just want to stay for the committee, the total expenditures shown to us for RSPMI program and what's shown on Stevens Group report is about $100 million difference. And I do not know where that come from, but I would like to take a look at that, or maybe members of the task force could probably look at that, why the big difference is, because that means a lot. There's a lot of differences in dollar-wise. And the next portion of this is about the 90-day treatment plan that we currently do every 90 days, a treatment plan review from my clinical folks. She will talk about the clinical side. We don't see any effect of having this done other than additional cost that's been paid to the providers, which we estimate the savings should be $2 to $3 million on those specific procedure code. And we want that to be removed and maybe make it to 6 months, or even go with in similar line with the private providers, which most of them require once a year. I will leave that to the clinical folks to figure it out, which is the best approach to take. The second part about modification of current PCP referral process. Most of you know, most physicians that when I was on the state side, they get all these PCP referral requests. They have a hard time keeping up with some of these, constantly 6 months. Sometimes they miss it, or the provider miss it. Then provider get paid back all those money because you didn't have a doctor signed in. This is mainly we are talking about renewals. So we were proposing to tie in these PCP referral process through our electronic system that state had paid. Some may argue it was not enough funding that was given through the HIT program. So maybe enhance that, make this electronically possible, and also at the same time give the physician a chance to read those notes, certain segment of it, to reauthorize services if necessary. So we think this is an administrative savings, not direct program service. Our estimate is about $1 million. The final piece on this slide is a big one. This is a conversation with pretty much most private providers, and we also represent one community mental health center that providers were willing to take across the board savings of $17 to $18 million. That represents anywhere from 0.5 to 1% across the board cut. These are some other additional savings that we think there are duplication of services. For example, the current quality assurance process. Quality assurance means a lot. There are several pieces in there. There is value option who does it. There is my agents, my unit where I came from. Program integrity had a review process. Then you have other insurance companies have a different review process. Then you have DCFS, DYS, all the agencies part of DHS or outside of DHS We want that to be coordinated from a provider perspective as well as from a state perspective, which saves a lot of money. For example, I just put one example in here. When one of the vendors who does yearly quality assurance, so if they have a need to look at additional record based on risk analysis rather than just randomly selecting, oh, we're going to do this because we want to do it. Not for those reasons, rather than based on risk analysis. To do those, it'll save the state funds, it saves the provider funds, administrative time, and we project that to be about $1.1 to $2 million in savings. And very similar approach on coordinate any necessary retrospective or any other reviews that's been done. So we are also looking at a savings about $2 to $3 million. I'm kind of rushing through because we got other slides. My colleagues here want to talk about clinical services, so next. No. This is often talked about. I think Stevens Group brought it out. There was a high utilizer of mental health services. These are basically represented by chronically ill, eligible disabled, or commonly we refer to them as 911, that come from the Act 911. So they do cost money, they do cost additional funding. So we are asking that to be removed and maybe have a per day payment structure to eliminate the unnecessary services or services that can be accomplished on a per day payment structure. There are several examples that you could look at on current DHS Medicaid payment structure system that can be patterned after. And lastly, elimination of episode of care payment for behavioral health. We're only talking about behavioral health. There's conversation, discussion, agreement, disagreement. Last count we got, I have gathered about $200 million counting. That includes payment to McKinsey Group, or all the other providers who partnership with this process. Today, I could not tell how much money it saved just on one episode of care that was implemented part of behavioral health, which is the ADHD. Nobody knows the answer. Only recent published document I could find was about $200,000. The state has never took the time to find out what happened to these individuals who has been moved out of ADHD, what the cost is for those people either going to emergency room or going to other primary care physician, writing other script. We don't know the answer to that. So without that savings, a established accountable savings, we feel this is not necessary for us to go forward with. And if you look at the Stevens Group report, all those are estimates. Even Stevens Group never put a number. We have been on this since 2013. There is no actual cost savings shown on this. With that, I will pass it on to Carol Moore.
All right.
All right, thank you again.
Oh, excuse me, just 1 minute. We do have 2 questions, and I would like, since we're going on to another clinical perspective, let me ask, Senator Cooper, okay, all right, go ahead.
All right, I'm going to be fairly brief. A lot of what you have already heard were things that I was going to talk about. The Community Mental Health Association has spoken to a lot of those. There has been a great deal of discussion in regards to the quality of care that has been provided across the state. And it's important for everybody to be aware of the numerous steps that I have to turn this way. The oversights that we have in place prior to the provision of service all the way through post-provision of service. We there are several steps, several approval processes. These are decisions on care that are made by a professional clinical treatment team that it evaluates each and every person who walks in the doors of a mental health center for service, whether it's a private provider, whether it's a community mental health center, whether it is any source of of mental health services. There's been a great deal of talk about a assessment. Boy, my words are gone. An assessment that is utilized across the board by all mental health providers, and we are more than willing to take part in development of that. It's something that we have discussed, as well as treatment plans, those types of issues. We have several different types of reviews, as Robin talked about. We have the on-site, we have each year by Beacon, which I may call Value Options because that's who they've been to us for many, many years. We have the retrospective reviews. We have our own national accreditation agencies that come in. We're not here to present complaints. We're not here to stomp our foot and say this won't work or that won't work. We're here in hope of being a part of the solution process to ensure the quality of services and does remain extremely high for the people in the state of Arkansas. I could go through, I have pages of studies, different studies that have been done that talk about how managed care affects the people and the clients that we actually serve, which is the reason why we're here. The main thing that I want to touch on is a statement that was made by one of my partners in the mental health field, that a related problem with the introduction of managed care into the health care plan is the idea of using a financial tool to control a clinical product. I labored for days on what I was going to sit here and say to you all today. And I thought, okay, statistics, and I changed my mind last night, actually. Somebody said to me, you need to go in there and be yourself and speak what you know. Dr. Baker is here. He can provide you with those statistics, and he can provide you with that specific information. But what I would like for you to know is, the statement has been made that the quality of services in Arkansas has suffered. And we would like to see those reports that the quality of service is poor. Across the board from all providers, I think we do strive. We would never sit here and tell you that there's not a problem, that there are not issues, that there are not those that would prefer to make a dollar. But that is not the reason that most of us spent years in school to become what we are today. Managed care inhibits the ability to serve, and that inhibits the ethical qualities of those of us that are licensed in the state of Arkansas. Do we do what's best for the client? Do we follow what we can get paid for? As far as an MCO makes the decision on what their medical necessity and evidence-based practices are, but yet it's the team of people, the psychiatrist, the therapist, the mental health paraprofessional, that actually see that person, evaluate that person, and know specifically what services and what level of care they need to improve the quality of their lives. I'm going to skip. You see, I made these notes this morning when I decided that I was not going to go by this. So I apologize for the broken. We've been working under the RSPMI system for approximately 14 years now, and it's by no way perfect. But we continue to perfect it every day. And we do that because we know that the folks that we serve are not your person that walks into the emergency room with a broken arm that can be set, a cast placed on it, and they go back to work in 6 weeks, they're good to go. We work with the child who has suffered trauma, the adult who has suffered trauma as an adult or a child. We work with that brilliant 27-year-old young man who had a successful career, and suddenly one day he woke up and he believes he walks in this world under hypnosis. Nothing is real, including his own child. He believes that the only person who can free him from this delusion is the Queen of England. We serve people from one end of the spectrum to the other. And yes, our system may not be perfect and there are flaws, but to begin a whole new process and to allow an MCO to determine what this person needs and what this person needs and the benefit they will gain, to give them the quality of life that is the most that can be offered to them. Okay, again, I want to go back to, we are here not to complain, but to be solution focused. We've come up, as Robin discussed, we've come up with many measures that are cost-cutting measures. And what we've done is we've sat with the Alliance. We have sat with the mental health group. We have sat with the behavioral health providers group. We've talked with DBHS folks, and we have worked with Value Options and Beacon and everybody across the board. We have come up with what we believe will provide above and beyond the cost savings that is needed in the Medicaid system for mental health services with doing the least amount of harm. And I'm not going to again talk about what Robin has already talked about and go through those, but the number one focus, and something that John Stevens said earlier today, it's not always about the cost. We understand the need for cost-saving measures. But as mental health professionals and those of us that serve, we also understand that each individual life matters and must be treated as such. Thank you.
All right, we're going to go to Dr. Baker, because this is all on the same subject, and my apologies to Senator Chesterfield. She did have a question, and now we have Representative Gray, but if you don't mind, we're going to take care of the subject and let you have your questions. Thank you. And
Okay.
Dr. Baker, you're recognized.
Well, one of the things that I'm proud of is being a member of the Alliance for Health Improvement, which was started about 2 years ago with a specific focus to look at the services we were providing to see if we could come up with ways that would be more cost-effective, better outcomes, and would serve the people that have mental illness. One of the big problems with psychiatry is that it's totally different than any other specialty. If you get a lump in your belly and you go to a doctor, he feels the lump, but he then starts a battery of tests which proves what the lump is. We don't have any tests, so diagnosis is much more difficult in mental health. So what we have to do is we have to be certain that the procedures we use for diagnosis are such that lead to reliable outcomes and reliable options for diagnosis, and then as we work with the patient to be able to tweak those diagnoses as we get more information. One of the problems with a one-of-a-kind standardized assessment is that it's very hard for anybody to walk in and on the very first visit to really be able to delineate what the problems that they are having is. So one of the things that the RSPMI guidelines have is they in fact have a required standardized assessment that is in their outlines, and our providers are using those and are in the reviews for if they were not using them. Value Options as a reviewer would obviously point out that difficulty. So we don't have any lab tests, so what we have to do is work with the individuals and their families and gather information. So what I want to present to you today is something that is a kind of an idea that I want to throw out, where there's an area that, in my experience in working with Medicaid for over 40 years, I think we have both a problem and a wonderful opportunity for improvement. And that issue has to do with the whole issue of the problems that arise from early childhood abuse. About 10 or 12 years ago, a study was done by the Kaiser Permanente Foundation in California, who were trying to estimate their healthcare costs, in which they did a variety of things, looking at their patients to see if they could come up with any predictors that might help them. Well, one of the things they looked at was adverse child events, and they came up with a group of questions that they asked 100% of the individuals that applied, and then over the course of many years, they've done very careful research looking at the predictive value of those questions and being able to identify patients that are in need of services for abuse and neglect, but also to identify and correlate those with the total health care costs that occur in individuals that have this past history of abuse. So what I would like to do, I'd like to go on to the next slide. This slide outlines the type of issues that they're talking about, the 9 questions they came out with. They have to do with the common things we think of in neglect, which is neglect, sexual abuse, emotional abuse, physical abuse, but they also occur with 4 or 5 questions that also look at disorganization in the family unit. When you come out with those 9 questions, they came up with a score. Next slide, please. It turns out that the score, which could be as many as 9, had a very sharp cutoff data, and when they found that there were 4 or more of these events, it was predictive of a very complex long-term mental health outcome and mental health requirements, extreme costs for medical care, and extreme societal costs. This next slide, please. This is looking at the data for the U.S. and the data for Arkansas. If this slide got all mixed up as it transferred to this, but I will make it corrected basically to say that on this slide there is no difference between the Arkansas data and the national data on the types of abuse that occur, with one exception. We have less sexual abuse in Arkansas than they did in California when this original study was done, and it's been duplicated in every state of the United States repeatedly. Now, if you look at that and say, okay, so they did these questions, they got this data, what does it really mean? What does this turn into for us? The next slide looks at, go back to that slide, please. This looks at 3 areas that are very important. One is when you have these adverse childhood experiences, one of the things that it does is it causes a lot of pain and difficulty and suffering for the abused child, obviously. But it sets in chain a group of events that occur that, if there is not early diagnosis and recommendation and treatment of this child, starts a lifelong battle that goes on to death. The next area in which it does, go back just a moment, the next area in which it does is it disrupts development. One of the things that's exciting about this whole new area of abuse is we're getting tremendous data now that shows that what happens to you as a small child leads to lifelong changes in your neurochemistry, your neuropathology, and even your brain structure. And that these changes lead to a difference in the way the brain operates when it's confronted with stressors, whether they be physical stressors or mental stressors. The bottom of that slide, the bottom of that slide, go back to that slide. The bottom of that slide lists all of the long-term consequences that occur from this abuse. And one is very interesting, and that's the one that says possible transfer to the next generation. They're even learning that the effects of abuse may alter genetic makeup in some way that may be passed on to the next generation. Next slide. Okay, this is looking, I'm going to skip that slide. Going down. Okay, this then says, let's look at these ACEs, and let's see if you look at specific mental and physical diseases, what is the data that shows, in fact, they predict? So we're looking at the first slide, we're looking at mental diseases. You'll notice that the blue columns is when you have that magic number of 4 or more. In each of the incidences, there is a correlation with what happened to you in childhood and what developed into mental illnesses both in childhood and throughout adult life. Next slide. This looks at the same data for selected health issues. And what you find is, again, this very striking correlation of the next slide, please. Now, this is a costly issue to tackle and to deal with, but let's look at what happens if you don't really deal with it. This slide suggests that what the cost was is an average of 1.8 million per victim that was identified in 2014. What they're projecting is lifetime costs. Next slide. This is another one that says if you took all of the people that had been abused in 2014 and you followed them, what would be their total health care costs through their life? $5.9 trillion. So the bottom line is that this is an issue that we've got to address and bend the Medicaid cost curve, because these are diseases, these are incidents that are happening that are drivers of total health care costs. And in fact, they are actually maybe the top driver of total health care costs. Next slide. There are cost-effective treatments. The University of Arkansas has had a program under the direction of Teresa Parker called the BEST program, and that program has been very helpful in training manpower resources for Arkansas so that evidence-based treatment can be delivered. This slide gives the top 3 evidence-based treatments. Next slide, please. Question is, do those treatments work? This is a slide that shows that cumulative evidence. Whether it be that they had behavioral health problems that showed up, whether they had full-blown PTSD, or whether they had stress related to things, each of those kind of varied conditions responded to adequate treatment. Next slide. What are the expected outcomes? Well, this is what you expect it in basically every area that is affected by that, because you definitely have a reduction of psychiatric costs, a reduction of psychiatric effects, the halo effects that we heard about this morning. They get greatly reduced. You also have to look at these most vulnerable citizens that we have who over and over have been abused and are having the most important part of childhood, which is the ability to be protected and trust to be violated in ways that starts this vicious cycle that will follow them throughout adulthood. Next slide. This is a slide that shows that using Arkansas data, this slide was, I think, it's the latest I could find, but it was based in 2010, and it really looks at things that lead to the high health costs related to this one problem. Next slide. I want to discuss with you just a second the concept of complex trauma, because what we've got here in many of the patients that you heard about today, both from the Community Mental Health Center and from our people, we've got people that have 2 or 3 psychiatric syndromes, that have drug and alcohol use, that have depression, that have anxiety, they may have psychosis, that have themselves been abused and as a result have never gotten treatment, and therefore they pass it on. Well, they pass on abuse, they pass on disruption of families, and they pass on health care costs. And one of the major things that this abused population do, they literally cannot get it together enough to be productive citizens and to be productive, so they end up being on the Medicaid rolls. I appreciate very much the opportunity of being able to make this presentation to you, and hope that it will stimulate some of your thinking about this vulnerable population. One of the things that I didn't have time to include, but the state of Iowa has been very progressive in their ability to put some of the major aspects of medical care into play. One, early diagnosis and recognition. They put this ACE interview every place there's an interface with a child, in the family doctor, the PCP, in the school, in the judicial health organization. They identify it early, they treat it, and then they start the process of healing that can ultimately reduce costs. In the new initiative we have with all the prisoners coming out, there is an extremely high correlation with being abused and doing criminal behavior. That's a population that we're going to have to look at that abuse and to be able to unwind it, to be able to make them integrate back into society. I thank you very much for the opportunity to share with you.
All right, thank you. We have some task force members that would like to ask questions. First, Senator Cooper, you're recognized for a question.
Thank you, Madam Chair. Basically, a lot of what I'm hearing today has to do with the basics of quality control, I believe, and whether or not we're losing the battle on quality control in the system. a lot of this is more detailed, I think, than what we've heard earlier from the Stevens Group. And I'd just like to ask Robin, do you believe there's a basic difference of opinion here with what they presented and what your view of it is, or is it mostly in the detail of the thing?
Thank you, Senator Cooper.
You'll need to turn your mic on. There we go.
Thank you, Senator Cooper, for the question. I think it's more of having been, even though I wasn't born here, but I lived here 34 years, worked part of the system, know the state of Arkansas, know the people we serve from all the way down to the south, to the east, the west. So having that knowledge helps us to understand the delivery of healthcare more efficiently, how we can deliver that. So there may be some not getting subject matter knowledge on each one of these topics that we were talking about. That could be, but no, I'm not here to say they're wrong or I'm right, but I think we go into in-depth detail because we've known this. This is all I know.
Okay. You mentioned a while ago there were some calculation differences. I think you mentioned 100 million somewhere there. Could you elaborate on that for me a little bit?
That was talked about the episode of care where we have spent about $200 million so far, at least to the account I have. We do not see any savings. So if it was a private business, if somebody asked me to invest $200 million, if I don't give them at least 1 or 2% return on that, they're going to fire me. I won't have a job. So we don't see, I've asked this question previously a year and a half ago when I just left DHS for detailed analysis of how much savings have you collected, not identified, not forecasted, not projected, have you collected based on a episode of care relating to ADHD. I still don't have that number. Well, I've seen somewhere it was published about 200,000. I don't know how true that is. So again, not to criticize the process, it tried, but there is no cost saving. It's time to fold it up. Start the process, what we have already had. And I think some of the slide that I missed was, we have gone through this managed care 14 years ago. Most of you know that we have gone through this managed care. It lasted 9 months, right? We lost about $14 million because we are such a rural state. We could not get enough providers to enroll, to provide services. Why are we even discussing? That's my question. I apologize, I missed that slide. I had a few other stuff in there. Thank you for that opportunity.
Right.
Thank you. One more question, Madam Chair. You mentioned being passed on to future generations. Are we talking about behaviors being passed on, or are you talking about genetic changes being passed on?
Well, both, because it's very clear that behavioral changes are passed on because the milieu you grow up in, you incorporate that. But there's some really very interesting new data that suggests that what happens to us doesn't change the core gene, but it had changed some adjacent genes called defender and promoter genes. And those are genes that help us modulate to be able to have distress. So if we have good defender genes and we are under a lot of stress, we will be able to resist that stress without developing overt symptoms. If we have 2 promoter genes that we got that are these associated genes, they're modulator genes, that if we have those, then we're much more likely to develop that. And if one of the examples of that is in both the New York City bombing, the 9/11, and in the Oklahoma City bombing, Carol Norwood, who is a psychiatrist that's interested in genetics and trauma, she drew blood on all of the people that had PTSD develop after those events. And very interestingly, they all had a modulator effect in that one of their transmitters of serotonin, instead of having 6 valences at the end of the gene, had only 4, making it therefore a less effective tool to be able to go out and grab the serotonin, pull it in, push it on a receptor. And it's very striking data. Now, you can't do all of these tests yet in psychiatry, so you can't predict who's going to do it. They're research studies. But yes, there is data that things that are, it's clear that psychiatric diseases are highly genetic, but there is increasing data that in children that have abuse, that alterations of their genome can occur that then is passed on to their children.
Thank you for that explanation of that. I thought that's where you were going. I'd seen that just a few days ago. Thank you, Madam Chair.
All right, Senator Chesterfield, you're recognized.
Chair, I think Robin has already hit on my major question, because I know he's been around here, 29 years? Something like that. We won't talk about it. We've both been around probably as long as the other. When you alluded to managed care, that was one of my questions. Has it been tried before? Because I continue to think there are no new things under the sun. Approximately when did we practice managed care? Would you mind repeating that?
I believe it's about 14 years ago, so I'm going to say about 2000, 1999. Don't quote me on the exact date. So we did try managed care on mental health only. That's all we tried, just on mental health only. We probably lasted about 9 months, and I think, my memory serves me right. We could not get enough preferred providers to join in to accept the rates.
That accrued under managed care?
Right.
Okay.
And then it did not work on smaller town like, El Dorado, or go down to McGee. You're not going to find mental health providers available to provide these services.
And one other quick follow-up, Madam Chair, on credentialed social workers, and reading the report, that struck me as something that is of great concern. How do we go about the business of perhaps fixing that so that we can get more credentialed social workers, because that's going to be critical whether you have managed care or we continue down the path we're going at this point?
I think we have addressed this concern with the Prison Reform Task Force, a part of the discussion that I serve on. This is not just on managed care, even on private option currently we were asked to adopt what Medicaid currently credential individual to be a professional mental health provider, to be recognized and credentialed into those programs. And if managed care was one of those, the will of the people, then we should also ask those to be passed on to the managed care side too.
But you have a shortage, you're saying. How do we address the shortage of social workers that we currently have? Maybe Carol, can you
May I
tell?
speak to that? Am I on? We currently are very limited. Medicaid is open with supervision for us, for LACs, LPCs, LCSW, LMSWs.
And I know you know what all of that means, but you want to slow down?
There are different levels of licensure, but insurance providers as well as managed care companies do not allow those other than independently level licensed folks. We are all mental health providers are snatching folks up as quickly as they're coming out of graduate school. The time frame that it takes for a social worker to be licensed at a master's level is much quicker than the process that it takes for a licensed counselor. If we can change that time frame, and that's something that we've been working on, but also to change the insurance acceptance of those providers that are qualified to provide services. Especially with our current insurance in Arkansas, they're so limited that providers are having to turn people away because they have nobody that's qualified to provide the services.
But if you do a shortcut, wouldn't that cut back on quality?
No, ma'am. No,
Okay.
the folks that we have that are not at the independently licensed level are very closely supervised, and that is not only by their boards, but by the providers in regards to regulations that are handed down to us from DBHS and Medicaid.
All right, thank you,
So the
Madam Chair.
quality is not the issue.
Okay, thank you.
All right, thank you. Representative Gray, you're recognized, and then it will be Senator Ingram.
Thank you, Madam Chair. Kind of what I'm getting out of the presentation, it kind of boils down to two things for me. One is you're willing to cut your own reimbursements, and you're willing to cut the least critical services like the yearly evaluation as cost-saving measures to do two things. One, to keep managed care out. That's how strongly you feel about it. And two, to aid the governor in his plight for his $180 million. And I applaud your effort in doing that. And I'm going to say that I almost disagree with cutting services. I know why you've done it, but here's part of my thing. Everybody talks about the growth in behavioral health. Well, I can tell you that the number of patients that are even seen in a clinical setting, primary care, if you ran the numbers, I'd like to see the numbers. I would estimate that it's been a 75% to 100% growth in the number of patients who have behavioral health in the last 10 years. I don't know how to tackle that. So I guess what I'm saying is I understand that growth curve is much higher in your line of business than anywhere else because I see it on a daily basis. So my question for you, my biggest concern with behavioral health is the fraud. We hear about fraud and inappropriate billing. And Robin, this would go to you more than likely. In all your time that you worked for the state, have we ever done any type of fraud prevention? Have we ever gotten with HP, who has our MMIS system, and said, let me see the patterns of billing. I want to look at certain providers and how they're billing. Have we ever done any fraud detection at the billing level? I would rather see cuts in us reducing fraud than having you cut services to patients.
Thank you, Representative Michelle Gray. The answer to your question is, if you asked me this question 12 years ago or 10 years ago when RSPMI was born, I would agree with you. There was lots of issues relating to it. Over the time, in credit to DHS and credit to people at the administration, had helped to reduce that. We have changed the program. It still needs to be done. There are still issues. There are still problems. Never going to say nothing. And I came from program integrity, running it for 12 years. So should we do more? Yes, we should more. But I think this is my mistake publicly. I supported the OMIG creation. I think OMIG has been a real failure, in my opinion, after 12 years working, creating the program integrity. It really has failed. It has lost 22 staff from the whole group of people with the knowledge. They have cut down lots of stuff that I put together to create in conjunction with CMS, who provided lots of leverage and funding. So that's a different topic for another day, but it can be improved to reduce those fraud and abuse. We did put together, just before I left, for Optum Solution to have the fraud detection tool, but how it is used, I cannot answer that question right now, and maybe you should be asking that to the OMIG director, how they're utilizing it. The tools are there to do that. But in terms of, I would estimate maybe actual outright fraud, maybe 1% you would add in the program. If there is a improper billing, stock didn't sign, all those are arguable things. Did they provide the service? Yes. Did they suffocate the sign? Yeah. I mean, we have other rules and regulation in place by the state to protect those type of stuff. So it's a difficult topic on those issues.
Okay, and like you said, 1%. I'd rather see us really work on fraud prevention and save that 1% that way than save 1% through cutting out that annual assessment or some other service, I guess, is what I'm saying. Is I haven't been in this office very long. What are we on now, like 9 months, and I have yet to hear of a single case of fraud in any healthcare aside from the drug issues we've had with some of the physicians. So I guess I just want to recommend that we actually use the data that's through MMIS to see. I hear all the time of behavioral health. There are all these different services that overlap on a daily basis. Things like that just need to be addressed. So I guess I'm just recommending I'd rather look at fraud than cutting any type of service.
Could I respond a little bit to that? Because one of the issues I think you need to look at is what you might call pseudo-fraud. Is it pseudo-fraud if you misdiagnose a patient, put them in the treatment, don't have the right tools to get the right diagnosis, getting the diagnosis right is the most primary care of providing evidence-based care. That is your evidence in psychiatry. Then is it pseudoprod if you don't see that patient enough to re-diagnose them, because we don't have lab tests. We have to go by our first impression. Do you not reassess that? Do you not do that? There's a lot of places that I think pseudoprod is a ridiculous term in some sense, but the net effect is that dollars are wasted when you don't have the right diagnosis, when you don't have the right medicines being treated, the right therapies being given that are evidence-based. And in psychiatry, we now have evidence-based for a vast majority of what we treat.
Okay.
May I respond?
All
May I
right.
respond quickly to that?
Yes. Mm-hmm.
We are not talking about deleting services, basically. We're talking maybe an individual session from 60 minutes to 45, a group session from 90 minutes, or a family therapy session from 90 minutes to 60 minutes, a mental health paraprofessional intervention from 2 hours to 60 minutes. We're talking about limiting the time frame allowed on those and cutting back on services that way. But we also have to speak to the important factors of the services that need to be added, which are the care management, the case management, so to speak, substance abuse issues, and keeping programs that have been proven to reduce the length of time that a person may need to be in behavioral health services, such as our system of care services. So it's not a matter of taking away services or not providing services. It's a matter of compacting and utilizing them more efficiently.
Perfect, thank you.
All right, thank you. Senator Ingram, you're recognized for a question.
Thank you, Madam Chair. First, I applaud you for looking inward and making these cuts. If we had every group that came in front of us that offered these type of cuts, this task force would go down in Arkansas history. I think we've talked a little bit about symptoms. Help me on process. That's the one thing I don't understand. An individual is referred to you. I assume that that individual is then evaluated by a professional.
Yes. The RSPMI guidelines say that the evaluation will be done by a mental health professional as the initial step. That is then followed by a review of that data by the physician and a certification that based on the data they reviewed, that this patient does meet or does not meet criteria for RSPMI services by being severely mentally ill. Now, if then the next step is that patient is seen themselves by a physician, and at that time the diagnosis is then recertified as saying, based on my own contact with this patient, I certify this diagnosis. Now, the process also that goes on in that time is the development of a treatment plan, and that is done through team meetings in which all of the components are brought together, and it's decided what's the most cost-effective, evidence-based way to approach this patient. And in terms of very complex cases, you often have to sequence it. You have to do something like a very paranoid patient. You have to build up trust before you can ever do anything with that patient, and it takes a while. An abused patient, we heard the word, trauma-informed care. It's more than words. A patient that's been traumatized like those I described, they don't trust anybody. They're constantly on guard. Their brain is working on their emergency system all the time. They can't think, they can't use their frontal lobes to think and plan. So you have to have the kind of care that is sensitive to that. And systems such as at the Community Mental Health Center programs and at RSPMI programs, we all understand that, and we design our programs to deal with that in a way to get this patient so they can be ready for improvement.
So I would assume then that the first person that does this evaluation is somebody that's an independent person. They're not on staff. They're not being paid for by the provider.
No, they're an employee. They're being paid for by a provider, and their job is to be professional, is to be truthful. It's just like any other medical doctor. If you look at a medical office, you don't ask somebody to come in before a medical professional assesses a patient. It's done there in the sense that this is their recommendation. That is then corroborated with other data and other evaluations. And basically, what you come up with is you come up with a kind of patient that it looks like a particular kind of treatment and program would be needed for. On the presentation that the Stevens Group did today, one of the things that they pointed out was that there's a fair number of patients that come to RSP, to providers that only get $1,000 worth of services. First of all, the no-show rate in the average Medicaid population with mental health problems is around 40 to 50%. Secondly, some of those people that come in, that first screener says, this patient's not sick enough to need our services, and they go back to the other doctor. And some of those are dropout for other reasons. But, you know, it's a kind of a thing that once you get this evaluation, in psychiatry, all you can do is meet a set of criteria and be careful in doing it. Our interview that's given lasts up to 2 hours that those people work with. It's a semi-structured, evidence-based interview that every patient that comes in gets it. And every one of those patients gets screened for trauma, including those questions I showed, gets screened for risk, gets screened for substance abuse. Those are issues that are guidelines of RSPMI that all of our patients need to be screened for.
All right, you've said a lot there, but the answer to the question is that the person that does the evaluation of the patient is paid by the provider. And
Sure.
so in just short sentence here.
Sure.
So you're referring back to yourself.
Sure.
Okay.
And where the issue about the fraud detection comes is when you have your people review those charts and you see that there is a pattern in which those patients are not being abused. A person that is a quote independent provider is really not independent because their income is based on denial of services very often. So, you know, it's hard to find anybody that is independent totally, and you just kind of have to do like all other professions do, is you kind of have to evaluate a person, do the best you can, and try to get treatment, and trust the people reviewing you that, you know, that they will handle the fraud aspects.
Well, I know in the concrete business, if it came down for asphalt or concrete, I would recommend concrete every time. The last question I've got, Madam Chair, is once the patient is in the system, we have heard anecdotal evidence that sometimes this thing goes on for years. We're talking about 8, 9, 10 years. Does it ever reach a point where you have a patient that you're, let's just say, 3 years in to, and I can't help this person. I'm going to have to refer him to another provider. I'm going to have to, but I mean, I've had him 3 years, and or he or she, and we've really made no progress. You know, we hear anecdotal evidence that just people stay in the system for years and years on end without any progress.
There's more than one answer to that question. First, you have the chronically mentally ill clients who are going to be receiving services for a lifetime. And that's separate from who you're asking about, I'm sure. We do reevaluate we have treatment plan reviews that when the treatment plan is developed, it's specifically and individually set up for that person with goals and objectives. And all of this is done in conjunction with the client and or family if they're a minor or have a guardianship. Those are reviewed on a regular basis. And if something's not working, then we change it. And this is not just what we do, it's part of the regulations that we follow under RSPMI and Medicaid. And there does come a point oftentimes when one therapist may not work well with the client. So we may try an alternative therapist within our organization. But at times we also must sit down and staff that person and determine we've tried everything we know. It's time to refer this person to somebody else to see if they can come up with a new approach that might work with this person. And I think that, you know, people say we have competitors and we compete against this clinic or this clinic, and there's 3 in this town, and then there's not one for 100 miles here. There are enough mentally ill and behaviorally challenged folks in the state of Arkansas that we will never be able to serve them all adequately. So I don't think there are very many providers that you will find that will think twice about saying, you know, gosh, we've done everything we can do. Can we help set you up with somebody else and let you try something differently? The diagnostic assessment that we complete on your previous question in regards to this, that is a process of evaluation for that person that takes over at least, if not more than 2 hours, to ensure that they actually meet the criteria. We don't provide a lie detector test to our therapists when they are hired and come on board. Are you ethical or are you not? You know, I mean, it would be wonderful if we could do that. We have to trust in their judgment, and that's why those things are team decisions, which are also followed up by approval by Value Options, who is Medicaid's regulator. And they determine if the diagnosis is appropriate and if the services that we're requesting are appropriate. So there's several checks and balances to that process. And would we sit here and tell you that there is not somebody who's going to do something they shouldn't do? We would never tell you that. And that's something that internally, organization-wide, we look at and look for every day. We're very proud of what we do, but we do it for one reason, and we do it to enhance the welfare and the lives of the people that we work with every day. And it's that one person that can turn everything on its head and make the whole system look bad.
Thank you, Madam, excuse me, you're back, Mr. Chair.
Thank you. So I just want to do a quick time check for everybody. So we've got so many very, very important and emotional and critical issues to talk about, and so many people on the agenda, and I still have more questions up here, so I'm going to get back to them. But what I want to do is just give people a concept of what I'm seeing for where we're going to be for time. So, you know, there were, I think, 7 elements on the agenda to get through today, and so far, this afternoon, and so far we've gotten through part of the first one. So what I'm going to do is at 5:30, John, are you still going to be here at 5:30? At 5:30, we're going to go to agenda item K, and at 6 o'clock, we're going to stop. Now, if we get done before that as a group, that's okay, but I just want to let people know where we're headed, because I want to end the meeting today by 6 p.m. So where we are is we've got another question here, and then we've got group number 4 for item E to come up and talk. And if we can think to ourselves, how can we have the presenters kind of do the presenting in such a way that key questions that get into lots of levels of details can kind of be handled one-on-one separately, or notes taken to get the input to John and his team so that the key action steps that come from the sharing can be incorporated by John and his team, and that can be handled kind of offline, or we can ask John and his people to take an item, and rather than trying to wrestle each one of those things to the ground, and even though I'd like to do it and I love to do it personally, we're just not going to have enough time to let the 20 or so people that have come here today to speak get a chance to share it all if we don't try and think about this a little bit differently. So I wish I had a better answer, but I think that's the best thing that I can come up with. And with that, what I'm going to do is recognize Representative Flowers. I believe you're in seat number 81.
Yeah.
Representative Flowers,
yes, I am.
You're recognized for a question.
Thank you, and thank you for that reminder, because I did have several questions, but I'll limit it to one. As I listened, and especially to the Harnessing Childhood Trauma presentation, Dr. Baker, I was struck by how overlapping a lot of these issues are, and sort of the root cause focus of that presentation. And then I thought about how a lot of those issues are addressed by the same agency in terms of the work that DCFS does in child maltreatment and that kind of thing. And I'm wondering, though, in terms of addressing it from that perspective and even looking at the prevention focus, where does that fit, since based on the testimony that I've heard today, managed care at least hasn't worked in the past? Where does the reform and the mental health care in Arkansas fit in the care management structure that we're seeing in the patient-centered medical home, for example? Because I've, over the years, always seen mental health care as sort of separate from health care. So even when you're talking about assessments and diagnoses, do you think that there's any room to incorporate what we're seeing in healthcare with the care management through, for example, patient-centered medical home, for mental health to be a part of that broader umbrella of care?
I think a great need is going to be to educate the medical providers about this information as it becomes more practical, so that they can understand it and understand the correlation between the poor outcomes and this past history of abuse. That's one of the very big missing steps. For the major aspects of these people need to be under the control of a psychiatrist and a team that understands trauma, works with trauma, and understands that these people will have all kinds of negative outcomes if you work with them in the standard way. They just don't fit the standard progressive treatment for a medical problem.
Thank you.
All right. I think we're down to our last question on this, and I'm saying that so if anybody pushes their button, we'll know they pushed after the last question. Senator Sanders, you're recognized for a question.
Thank you, Mr. Chair. Thank you for, I'm looking through the recommendations that you've made, Mr. Ravindran, on changing sort of the units. On the first 2 points, it says maximum allowable units for certain individual therapy codes adjusted from 60 to 45 minutes. Is that on a provider basis, or is that on an individual basis? You know, I've been talking about abuse and fraud and RSPMI program for years, when you wore a different hat, and you know, sort of the construct of paying paraprofessionals $6, $7, $8 an hour and billing the state $40 an hour. Who wouldn't like that arbitrage? I mean, it's a great deal. But you know, one of the problems that we'd identified a couple years ago was we had RSPMI providers who were operating under multiple names, who were in schools, doing in-school services, providing you know 3 hours or 4 hours of therapy, and then the kids supposedly would go to the same provider, but it would be under a different name and receive more hours of therapy. So my question is, are we drawing the distinction on the individual, or are we drawing it on the provider and being able to use services or duplicate services essentially? And is there still as much fraud and waste and abuse in the system now when we had these conversations before, or have you been able to kind of whip them into shape a little bit?
Thank you for the question, Senator Sanders. I did address that question a little earlier. You could never wipe out there is no fraud in this program or any Medicaid program. We trust the individual who provide the services. That's the society we live in. We trust you, then sometimes we find somebody did not kept that trust. But as a pure fraud, from my experience, I could probably
I think it was more waste and just more waste and abuse.
More waste, yes, there is
stuff doing harm to kids, that sort of thing.
I call that improper billing. Possibly there are improper billing in terms of not signature, not timely, maybe overlap, maybe not put the right time you provided the services. Those type exist, not to an extent to overall the system to a managed care model or some other model. We built this program for the past 12 years, has near perfect, or at least 95% perfect, to a point. There are still some more things need to be changed. Absolutely agree with you. But we should not throw the whole thing to a managed care program and start all over again. And we have seen already how much efficiency my previous employer has been in the past 2 years. How much money we have spent on things that we wasted. Well, that's one of the reasons our concern is, do we want to go into those managed care system and start all over? We did that 14 years ago. I mentioned that, and we lost money.
So
we lost all
what's the
those.
total amount, again, the total amount of savings that you guys are bringing to the table?
We are projecting close to $30 million program serving collectively. So obviously, we're willing to sit down, go through one by one how we can achieve that. The governor wanted to make sure that we have enough savings to accomplish the substance abuse piece, as well as a care coordination piece to go with this program, which is pretty critical for prison reform. So I think we can identify that.
Well, this, one, I applaud you. Again, 2 years ago, you weren't working with these guys. I can remember meeting in the basement of the Capitol cafeteria and everyone telling us how they can't, there's no room to cut, there's nothing to cut, we're maxed, and if we cut, we're gonna be turning children loose and all this sort of things. But it's amazing how we've come up with actually areas where we can save money. So I applaud you for identifying those areas, and I think it's probably a little late to the game. I think the governor has sort of outlined kind of what he's thinking on this, but I appreciate it, and thank you for your work.
Thank you.
Okay, it looks like I spoke too soon on John being able to meet at 5:30. He's got a meeting that he's got to go to at 5, so what we're going to do is we're going to move him to 4 p.m. and do 4 p.m. to 4:30. Guys, before you leave here, I've got one more question from Representative Murdoch. If you guys could stay there for one more question from Representative Murdoch. So I spoke too soon on last question also. But I just want to let everybody know that the 5:30 for John Stevens is going to be moved to 4:30 to 4 o'clock, so that we can get him in before he needs to leave for his meeting. So wherever we are in the agenda, we're going to break it at 4, have John come down and do his last section, which is section K on the agenda. We'll do that without objection. But right now, we'll take our last question. Vice Chairman Murdoch, you're recognized.
Thank you, Chairman. Real quick, how effective do you feel like the Office of Inspector General has been?
Representative Murdoch, you put me in a tough position because I managed that unit for 12 years. I built it from scratch. I'm not going to say it's useless, but it needs tender loving care, new change of management. It lost about 22 staff, at least to the best of my knowledge, since I left a year and a half ago, who are seasoned staff, who had inside, I call them state Medicaid experts, SMEs. I won't leave it like that. Sorry.
Okay, well, maybe we can talk offline a little bit more about that.
I'll be happy.
Thank you, Chairman.
All right, thank you very much, folks. And now we're to group number 4, which is DHS, Charlie Green and Julie Meyer. And again, as you can see, I'm really struggling. I put way too much on the agenda, but it's very I don't have the guts to break people's hearts and tell them no, they can't speak. So that's part of my problem. But I'd appreciate anything you could do to help us expedite.
Thank you, Mr. Chair. I'm Charlie Green. I'm the Director of the Division of Behavioral Health Services at DHS. With me is Julie Meyer, Director of Policy and Planning. She's going to get into the meat of a presentation, and we're not going to do the whole thing. We're just going to hit the high spots. But I do want to take this opportunity to make sure I thank all the provider associations for working with us and for coming here today and offering suggestions. I also want to thank the Stephen Group. Richard and John have been real good to work with. Their expertise and their feel for this kind of work has made it a real collaborative effort as we work through where we want to be a year and 2 years from now. And lastly, I want to thank the task force. Y'all didn't have to go about it in a way that you let everybody have their say, but you spent many long days up here, and I know people appreciate that. I know the parents and the stakeholders do, And I applaud you for sitting through some very long days of testimony. Behavioral health services, if you don't know, besides overseeing the community side of behavioral health that you've been hearing about today, also operates Arkansas State Hospital and Arkansas Health Center, which is the state's only state-operated nursing home. We, in the past, and for history purposes, y'all have been seeing me come up here for years, but it was as the DDS commissioner. I've been over at Behavioral Health now for almost a year. I came right at the end of their process of developing their payment improvement initiative. We've been working closely with our stakeholders and with policymakers to try to move that forward as quickly as possible, given the situation we're in with the fact that we have a healthcare task force and that the governor's office and leaders in the legislature want us all to take a real thoughtful look at our Medicaid program, including behavioral health. So I think Representative Gray asked why we didn't move forward with care coordination. One of the reasons is we're trying to fit it into a more global movement and see where our place in, whether it's an 1115 waiver or some other kind of reform that Medicaid's going to go through here soon. Behavioral health as a division has not been right in the weeds on Medicaid operations with regards to things like episodes of care, other types of just day-to-day operations with the RSPMI program until here lately. We are now, as I think Robin mentioned, having subject matter experts over at OMIG now, that we are being utilized more with that, and our clinical people are being utilized to help design what we think a new program for behavioral health care should look like. In addition, our clinical people and Julie and myself have been meeting with other stakeholders outside of our area, such as the Sheriff's Association, the Association of Counties, the other people you've heard mentioned here today, because what we do reaches outside of the mental health and substance abuse community and has a pretty good sized effect on the criminal justice system and how many folks we have incarcerated at any one time, and what kind of care do they need, what kind of care do people who've been arrested for, somebody mentioned low-level crimes that have substance abuse and mental health issues need. We've enjoyed working with those folks, and we think we have a way to move forward. Julie's going to talk about a little bit more. The last thing I want to say, and I do this every time we come over here, is just a reminder, and I don't need to remind this group, but I'm going to. We can't miss this opportunity. We've kind of stumbled along with behavioral health care in Arkansas for quite some years, and it's not for lack of effort. The people you've heard from today, and I was Carol and Robin's colleague for years, those people are good people, and they want to take care of our Kansas with mental health issues and substance abuse issues. Like all caregivers and clinicians, that they tend to want to serve, they want to help everyone. I'm the same way. When a mom comes to me or a brother or sister says, you got to help my family member, I want to move that line as much as I can to get their person in, their family member in for treatment and get them all the help they can get, because that's just my nature. However, sometimes the people that are writing the checks and having to balance the books have to put their foot down with us. And we want to make sure that we develop a program that allows for that and allows for the good treatment people you've been hearing from today and all our network across the state to keep doing the good work they've been doing. We just want to make sure they're doing it with the right folks and that they're providing what they need.
Can I interrupt you? We've got questions piling up. So first, we've got Senator Ingram. You're recognized for a question.
Charlie, is regards to RSPMI, is on licensure, there's a moratorium. Is there a moratorium on those licenses now?
That's correct. We had about, that's the one note I missed here. We had about 12 to 14% growth going when, if y'all remember when Dr. Allison first kind of rang the alarm bell years ago on Medicaid growth. And one of the actions the department took was just put a moratorium on new RSPMI sites. That's not a hard moratorium because it is Medicaid, and if we found an area where there was a shortage or an access issue, we would issue a license. I think we've done that maybe 1 or 2 times.
What year was the moratorium instituted?
2012, I'm looking back here for some help, and everybody's looking at their phone.
2008.
Right, we got 2008 and 2012, so somewhere in there. It's been in place quite a while. It was
I
supposed to
bet
be
Rusty knows, so I'm
I
gonna
bet
go with
Rusty does know.
Cranford.
It was a short-term solution, and it's ended up being a long-term intervention. It's probably not a good way to manage access, but it's what we're using now.
And the solution was strictly just to try the moratorium to try to put a cap on the cost?
At the time, it was just basically to throw an anchor out and get it stopped until a more clinically based solution could be developed.
Well, then, I understand on the cost side, but I also heard testimony previously from Carol and Robin that managed care was a disaster because there were no providers in rural areas. But yet we've put a moratorium on which wouldn't allow for any additional providers in any rural areas.
Well, as I said, it would allow for us to grant a license to any county, and we use the county as an area that somebody could demonstrate to us was underserved. We've had, I think at one time, 4 counties that had no providers. Somebody has gone into one of those counties. I think we have an application pending for another one. So we do have a way to help the rural areas. We have a great number of RSPMI providers, and 53 in Arkansas, and they have multiple sites. They're in a lot of schools. So we feel like we got adequate coverage in the state right now. We do have a way to deal with it. And I don't want to touch on whether the managed care issue from some years ago, but I think maybe there might be a little bit more to that story as to why it didn't work, so.
I'm sure there always is. Thank you, Charlie. Thank you, Mr. Chair.
Senator Sanders, you're recognized for a question.
Can you pass over me and go to the next question real quick? I'm trying to pull something up, if you don't mind.
Charlie, you're on.
Okay, still our turn. Well, then I'm going to hand it off to somebody that actually knows what they're doing. Ms. Meyer is going to run you through our PowerPoint.
As Dr. Green mentioned, my name is Julie Meyer. I'm the Director of Policy at the Division of Behavioral Health Services. In the name of brevity, I'm going to skim over the first 3 slides. This first slide just gives an overview of the different programs that support behavioral health and Medicaid. We spend a lot of time talking about RSPMI, and rightfully so, but there are other programs that support consumers and families across the state as well, and if there's any questions about those, I'm more than open to answering those. The next slide just presents some of the numbers regarding those programs. The Stevens Group did a great job giving that overview, talking about our core spend, Halo spend, and then how many individuals we're serving per year. Our third slide here also echoes what the Stevens Group presented this morning about how we're spending a great majority of our dollars on those top 20% of clients. So as this slide states, 81% of our total costs are covered by our top 20% of clients. Okay, and as Dr. Green started to talk about, we really believe and know and have seen in other states and in programs that we've already instituted in this state that the behavioral health system presents tremendous opportunities to not only assist clients and families and children in moving towards recovery and being functional citizens of our state, but also in assisting other systems, specifically our criminal justice system, which we know we've been working so hard on, and we've been working with the other task forces in this issue, along with juvenile justice and then child welfare. So just to touch on, there's a study that came out from the federal government that states 80% of state prisoners, 72% of federal prisoners, and 82% of jail inmates across the country suffer from mental health and substance abuse issues. And we know that the behavioral health system can present opportunities for diversion from that system, and then also assist in the reentry process to ensure we're keeping folks in the community once they're released and in the community prior to going into jail or prison. We've worked really closely with the Sheriff's Association and County Association and also our community mental health centers to come up with some ideas on how to tackle that, and we'll touch on those a little bit later in the presentation. I'll skip down to child welfare. And to the second bullet, we know that here in the state, our Division of Children and Family Services, has recently put out a report that substance abuse is now the most prevalent reason why children are taken out of their homes. And if we could ensure access and quality services to their families, we believe that we can really make a dent there. And I think that really also echoes the great presentation that Dr. Baker did on the ACE study that showed the different areas that children struggle with who experience trauma. And we believe that our behavioral health center and the great providers that you saw earlier really can address some of those issues. So to make a more meaningful impact and to take advantage of those opportunities that I just spoke about, we believe that these 5 areas, which I'm going to go more into in the future slides, is if we need to make substance abuse treatment services more adequately accessible. There was a question earlier about if the funding going out for substance abuse treatment right now is enough, and we're going to dwell into that a little bit further. We also lack access to a continuum of crisis services. Care coordination is not a reimbursable service. In this state, we believe that there's an overutilization of residential treatment for children. Compared to other states in this country, we are maybe number one, number 2 in terms of utilization of residential treatment, and that's not somewhere we really want to be in terms of rankings. And also, there's not an emphasis on family support services and other evidence-based practices. So to go a little further about substance abuse services, currently within Medicaid, we have a program called the Substance Abuse Treatment Services. It provides substance abuse outpatient treatment to adolescents and pregnant and postpartum women. And it provides a limited array of outpatient services to those eligible populations. In state fiscal year 2014, about $0.06 million were billed, only 187 clients were provided services through that program, and there's only a little over 1,000 claims billed. We believe by enhancing these services and expanding that population who can receive those services, we would be able to make a huge impact on the child welfare system and also the jail and prison population, and that the return on investment on providing those services would be excellent. Questions here? Another area of services that we do not currently offer the full continuum of is crisis services. We have a pocket of them across the state, and they do a good job at what we have. But we know that providing the whole continuum of crisis services can dramatically reduce inpatient hospitalization, ER utilization, and jail overcrowding. And that those services that could assist in those areas would be acute crisis units, crisis response and intervention, and substance abuse detox. We spent a lot of time with our community mental health centers and the Sheriff's Association and County Association talking about the need for crisis units. You heard a little bit about Bexar County in Texas and the great work they're doing there, and a lot of that is centered around the utilization of a crisis unit. It's a short-term service that is a safe place to address a behavioral health need, and it's much better suited for those individuals experiencing that crisis than a jail or emergency room.
Excuse me, Senator Rapert, you're recognized for a question.
You got me on there. We've heard this mentioned time and time again throughout the day, and we know it's a problem. Can you tell me why that we don't have something in place to help with crisis management? Is there been something tried before and it just never worked? I mean, it seems to me that if we know there's a need here, so is there something that is impeding providers or others from helping in this situation?
Senator, we, in the last biennial budget, we did make a request for funds for this particular service, for a continuum service here. and it just didn't make it into the budget. Now, prior to that, I don't know if anybody's asked for it. It takes some money, and it also, but less than you think. And it also would take, I think, some adjustments in the Medicaid manual to make sure that we could pay for it in the settings that our partners at the community mental health centers and with the sheriffs could demonstrate.
Okay, so I want to make sure I'm understanding. Is it that there is no provider in place to handle this because we keep hearing that there's no place to put people? Or is it simply a matter of the fact that there is no money available to pay for what a provider actually could be doing?
We feel like we have the provider network to do it, and because we've had people come forward, we're not reimbursing, there's no money for it right now. Like I said, we asked for it, almost made it, didn't get it, we're going to ask for it again as part of this process we're in right now.
And if I might add, in the past, a few of our community mental health centers have had crisis units, and they have just not been able to keep them going due to financial constraints. And they have worked, and they have shown good outcomes.
Okay, well, thank you.
Okay, and just to continue on with saying this, and I have to, but there was recently a report that was presented to the Behavioral Health Treatment Access Task Force that showed that research found that 1 year's worth of trial and jail time for each mentally ill person cost the state about 20 times as much as crisis treatment and counseling for the same person with mental illness. Another service that we've been talking about all afternoon, and I'll be short, is care coordination. We know that the return on investment for care coordination, it can be significant. It assists in managing not just an individual's behavioral health care, but all the other systems and services that they interact with. And I'm going to continue to go back to Dr. Baker's conversation and presentation about the effects of trauma for children and how that has implications in other systems and for their entire life. And this care coordination can really assist an individual, a child, and family in navigating a complicated system and having positive outcomes. And to elaborate on those outcomes through the division's system of care, which is a small demonstration project that we've been facilitating for years, we've been able to fund care coordination in small pockets around the state. And this graph just shows some of the fabulous outcomes that funding care coordination has shown, and they're cross systems and show cost savings as well. In addition to care coordination, our system of care has been able to provide family support services. We know that it is of the utmost importance to not just treat a child, but to assist that family as well, to assist keeping that child in the home, to keep them out of residential care, to keep them in school, not suspended, and being able to reimburse for some of these services listed here would greatly assist in keeping children out of higher levels of care, keeping them in their home and their community. We also know that those services are cost effective. This chart shows the total spend in state fiscal year 2014 for residential services versus our outpatient care, RSPMI, and the number of individuals, actually not just individuals, children that have been served. And as you can see, the average spend per child in residential a year is $25,000, and in outpatient it's $3,700. So we know that providing care in a home or community or at a clinic level in an outpatient setting is definitely cost efficient, but also can show great outcomes and keeps that child, near mom and dad in their school with their friends as well. Okay, this slide is an example of tiers of services that could be provided and shows the different types of services that we've talked about. Dr. Green did a good job of talking about how we have limited resources and ensuring that those in greatest need are receiving the services that they need at the right time and in the right place. So this is an example. This obviously can be modified, and we are looking forward to talking to stakeholders and all of you on how to make this best fit for our system and our families and consumers. As you can see, we have crisis services outlined along the bottom because we believe that those need to be available to anyone who needs them at that time. to keep them out of those higher levels of services and jail and child welfare, as we've talked about greatly.
I told Julie when she was developing this that we need to go ahead and call out where you see those assessments, and as I think Senator Ingram pointed out or questioned earlier, whether those are independent or not. And I wanted to go ahead and call attention to them, because that's where you're going to hear that's a bone of contention. All the stakeholders can agree on that we need more care coordination and we need better substance abuse services. And but when we get to assessments, it gets tough, because that's a real touchy issue. You heard, I think, Dr. Baker Lane Carroll talking about the process, and we know that the clinicians who are treating somebody have to do assessments to make sure that they're providing the right kind of service for that person and adjust it as it goes along. What has been absent in Arkansas is really strong, independently established thresholds. And as you can see on the slide here, people on the left in the counseling, they're the least needy people, and the people all the way up at the right are the most needy. Well, what we've proposed, and we actually had put stuff out for public comment, gotten public comment, worked with stakeholders a little bit more, and then are again waiting to see how the process moves forward with this group. But essentially it hasn't changed, as of having an independent assessment to establish those thresholds between the tiers of service, and then still have the assessments inside the treatment model, because you just have to have them, because things change for these folks pretty constantly, and you have to adjust your treatment modality to respond to it. So I think that concludes our proposal here today, and we'll be happy to answer any questions for you.
Senator Sanders, you're recognized for a question.
And again, thank you, Mr. Chair. And I want to thank both of you for coming and testifying. I know that, we've looked at a lot of payment reform efforts that we hear a lot of emphasis on sort of the medical side, the doctors, the hospitals, all those. But, we've had payment reform efforts to look at behavioral health, and they've been stopped. I mean, we've not moved forward on them, and it's not from a lack of want from some of us or from you. So I think I think in fairness to the agency, you've tried, and you've had pushback from providers who have been recalcitrant, who don't want to do anything. They've said they don't have to. They got people that can stop things, and so I appreciate that. I will sort of dovetailing off of Senator Ingram's questions. I pulled back the numbers that I had in the spreadsheet, going back on RSPMI expenditures by state for fiscal year, going all the way back to actually 11 years ago to 2004. And what we saw before the moratorium was in place was an annual rate of growth. Well, I'll just tell you, in 2004 it was 12%, in 2005 it was 18%, in 2006 it was 16%, in 2007 it was 15%, in 2008 it was 11%. Now, we put the moratorium in place. It went in place in October of 2008, and we saw a substantial decrease in the growth. We were at 3.5%. In 2010, we actually saw negative growth, so we were a negative, almost, not quite a percentage point. And then we saw an uptick in 2011 at 8.45, in 2012 4.7, negative growth in 2013. That's when we began sort of talking about. It's amazing when you start talking about reform and talking about, making changes, then there's sort of a sentinel effect that carries through. So we had negative growth in 2013, and then in 2014, we saw growth of about almost 2.4%. This is substantial, and we're talking, in 2014, we're talking over $300 million. What was the spend in? What was the total spend in 2014? Do you know?
In RSPMI, the total spend was, for children, 205.9 and 96 million, so 300 million.
Okay, and then so what about, what are we on now? what was the growth rate between 14, where we are, what are we seeing, sort of a year-to-year comparison?
Yeah, those numbers I just read off for state fiscal year 2014. Were you looking
Okay.
for annual growth?
But I'm just looking sort of where are we stacking up now, sort of year-to-year comparison. I mean, the point is, I mean, we've tried to do some things, and again, you can go back and pull copies of the Arkansas Times and read all kinds of stuff and see just this behavioral health debate has really carried on, spanned decades. So in what I'm concerned about is I hear people saying, well, we need to remove the moratorium. We need to remove the moratorium. And I look at, you know, what our rates of growth were when we didn't have a moratorium. And, you know, 12%, 18% growth is one thing when you're spending, you know, half of what you're spending now. But this is something that needs to be addressed. And I'm not sure. I think you guys have tried. And again, in defense of some of the providers too, because there are some good ones too as well. I mean, the agency hasn't always been a paragon of virtue in pulling off things as well. You know, we're not perfect, right? So I mean, this is a big issue. This is a big deal because when you talk about all these numbers and all this growth, and I look at the cost shifting that was taking place when we started putting episodes in for certain diagnosis, and the shifting that was. We're talking about kids there. We're talking about labeling kids, and we're talking about in many instances, in some instances, in fact, you know, it's fun when you get a couple providers in the room. They'll start talking about the bad providers, right? And they'll talk about the harm that certain providers are doing to kids. And I think we're just at a point now where we need to stop talking about doing something and actually do something that's meaningful. I honestly, I just don't have confidence that we're able to pull off anything unless we have some big help doing it.
I agree with you, Senator, and you and I have had this discussion about other parts of Medicaid, that it's, when you have a big network of people who are caring for others and are having a positive impact on families, it's very hard to get back to the real numbers and really managing the program and having to step around that emotion a little bit. And we may, you know, I think that's one of the reasons we've looked with the department and with some other populations at possibly having some outside help come in with this, and or to give us a good bit more authority than we've had.
Well, I mean,
Yeah.
correct me if I'm wrong here. I mean, if you look, I mean, we talked managed care failed before. Okay, well, look, we don't do a good job of contract management over at DHS. We know that. It's been established. And some things we do well, some things we don't, right? But I mean, it's all dependent on how you write the contract. I mean, what do we want? I mean, do we want providers in areas, in rural areas? Would managed care necessarily make sense in a rural area? Maybe not. I mean, but I think there are areas where when you look at what we're not paying for. I mean, when we're talking about the highest cost individuals being a sliver, not a sliver, but a smaller percentage, I mean, we need care coordination. We need to focus on them like a laser beam. Again,
Senator, can I interrupt you? Because I just kind of build on what you're saying, because I love where you're going, and Julie and Charlie, I think the presentation you gave was very, very educational and insightful. And in fact, pages 5 and 13 to me really kind of open the door to some areas that kind of get at this improvements. But I don't want to try and work them in this meeting right now. I would just love to strongly encourage you to take pages 5 and 13 and sit down with John Stevens and his team. Senator Sanders, if you want to be a part of that, to go through some of those particulars offline together and make sure that we get the very best of those thoughts for improvement so that John and his team can include it in the report of the recommendations. I think that'll be the most productive way to get some tangible stuff that the committee
Sure.
can react to.
If I could, Mr. Chair, and just the question being is, do you think, given all this history and all what we have and what you've proposed, do you think we're capable of actually pulling off any of the things that you've put in here, or are we going to have to look seriously at taking a completely different approach?
As you said before, we're going to have some help, whether it's help internally or help through an external contract. We're going to have some help, and we're going to have some help over in this building as well, because as you pointed out earlier, sometimes change is hard to make, and most of the legislators I talk to they've had really good experiences with the mental health and the DD and the long-term care providers in their area. And they think, well, it's got to be somebody else. And it is hard to draw that line. So we'll need help in this building, we'll need help over in the governor's office, as well as at the department, whether again through some contracted entity or that we beef up the staff we have. And as you rightfully pointed out, we could have done a better job in managing contracts in the past, and we know that we've got to do better about that in the future, or we're not going to have control over this. And it is going to affect somebody's children, and that's not right.
All right. Well, again, Charlie and Julie, thank you very much for the presentation. And now what we're going to do, John Seelig, are you here? Okay, and you've also got a meeting at 5, is that correct? Okay, so what I'd like to, I'm kind of thinking out loud here a little bit. What I'd like to propose to the committee, and I'm going to say it without objection, and then we'll see if we can do it, is allow us to do item G ahead of item F,